Hi, good afternoon and good evening from wherever you're joining me from around the world. Thank you so much for joining me today for my webinar. I'm Dr. Kiran Shankar speaking from the UK today, and we're going to be talking about minimally invasive workflows for better treatment of enamel defects. A big thank you to DMG Dental for supporting me for today's webinar and to Viva Learning. Thank you for all the support, and I hope the next hour you'll gain some insight onto how I treat cases and be able to apply it tomorrow in your offices. So just a little bit about me. I graduated around 12 years ago from the University of Birmingham, which is in the UK. I did 2 years of general dental practice before emigrating over to Australia. So in the UK, we have most dentists work under the government, the National Health Service, and that's where I did my first 2 years. But there's a lot of, you do a lot of dentistry, but maybe not to the quality that you'd like to do, because everything is time pressured and you're hitting targets. So when I moved over to Australia, I started practicing privately, similar to the US, and that's where I gained a lot of my skills. Unfortunately, it was quite far away from home, so I came back a year later and enrolled onto a part-time master's, which I completed in 2020. And I'm currently based at a office in Berkshire, which is not too far outside of London. It's a 10 surgery practice. We've got all the specialists and a lot of general dentists, and that's where I am today. If you're on Instagram, please give me a follow. I post a lot of my cases on there. So any follow-up questions from today, or if you want to see how I do cases, I'm always quite active on them. I've been very fortunate with Icon. It's a treatment that I started using around 6 years ago, and it has definitely changed the way my career has gone today. It's allowed me to write lots of articles on whitening and Icon, but also just generally in dentistry in the UK and how young dentists cope. So I'm very fortunate. I've been able to write many, many articles. And one of the biggest articles in my career so far has been being able to be featured in Dentistry Today. So thank you to all the team from Dentistry Today and DMG America for supporting me, and that's what's led to the webinar today. So hopefully you've had a read of the article that's in the magazine, because same again, there's step-by-step procedures on how to do the treatment. So this is my first lecture for America, but I have done a fair few lecturing events in the UK and across in Europe. So I really hope you can take something away from me today and be able to apply it into practice tomorrow. The great thing about this treatment is you don't need to really buy too many, a lot of equipment. Everything is easily accessible. And it's very easy to start on cases. There should be no real limiting factors. The dentistry I try and provide is minimally invasive. In the UK, I'd say we're probably a little bit behind compared to the US in terms of sort of the indirect cosmetic work that we do. So in the UK, we're very, very minimal, but with composite, you can achieve really, really great results without really having to pick up the drill. And that's what we tend to do in my office a lot. We're changing people's smiles without giving anesthetic, really not drilling the teeth, but providing great outcomes, in a couple of hours. And no matter what sort of dentistry you do, always try and be the best at what you do to try and allow your restorations to last as long as possible. So my question to everybody here who is watching the lecture is, what would you do if one of these patients turned up in your office or practice tomorrow? For many of these patients, they've been told for many, many years that nothing can be done. They get turned away by the dentist, or they get told you have to wait until you're 18 or an adult and we can place veneers on your teeth. And many, many patients are left walking around like this for many years. And we know now that this condition of anterior discolorations is impacting 1 in 8 children. So it's becoming a lot more common than it used to be. And we also know now the digital age that we're living in, social media, people are picking up on these conditions a lot more. And unfortunately, a lot more children are getting bullied for this sort of treatment. Hopefully, if I said to you, would you pick up a drill on these patients, you'd say no. because we know as soon as we pick up a drill on any tooth, we start the restorative cycle. So as soon as you pick up the drill and you cut a cavity into a tooth, inevitably that tooth is then going to need treatment again in the future and then again in the future. And every time you do a replacement of a filling, it's always going to get bigger and bigger, and then eventually turn into a veneer or a crown. Many of these patients that are coming in, they can be as young as sort of 8, 9 years old. And you really don't want to start treating them at such a young age with non-invasive options. So if you can offer them something minimally invasive, that would be a lot better for the patient. So if I said to you that these 4 cases were all treated without local anesthetic, no drilling of the tooth tissue, no injections, and all within sort of 3 to 4 appointments, wouldn't that be a great thing that we can do for our patients? Especially those patients who have been told for many years that nothing can be done. This treatment is life-changing. We have patients who, I'm very fortunate, we've got patients who travel sometimes 8 to 10 hours to come and see me. And they've been told by maybe 3, 4, 5 dentists that nothing can be done to help treat their teeth. And then they come in to see me and we'll do a consultation. We'll start off with some whitening and then we'll do the icon treatment. And the change you see in these patients from when they first come in, where they're really nervous, they don't want to look at you, they're holding their hand in front of their mouth, to when you actually finish the treatment is completely different. And I honestly believe this is one treatment that we can provide as dentists, which will change the whole life of this patient. They'll go from a young child who's very scared, doesn't have much confidence, to a completely different person. And if you can be part of that journey and be part of that child's life and change it, then, it's a fantastic product to apply and to give back to your patients. So with Icon Smooth Surface Treatment, there's a couple of new protocols that have come in. So sometimes you may have already tried to use Icon. So a lot of the times dentists will come to me and say, hey, I tried to use the product. I followed the step-by-step instructions on the box, but I didn't get the good result. And then that puts you off using the product. So hopefully from today, we're going to touch on a few elements that will help you get better results and help boost your confidence so that you can then get the same results that I'm getting in my office. So we always start with the preparation. So that involves the initial consultation and certain questions that you have to ask, which we'll go through today. It also involves taking a series of photographs. So photographs are so important in this day and age because if anything ever happens, you always have your photos from day one that you can go back to. But it's also good to analyze your photos. So just in case if the treatment doesn't work, you can always go back and look at maybe I missed something or didn't pick up on the right thing. Diagnosis is a key part of icon treatment. So historically, when dentists have done icon treatment in the past, they've just sort of rushed into doing the treatment. They haven't really given much attention to why the spot has occurred or what sort of discoloration it is. And they've just sort of followed the instructions on the box, and that's why the results haven't been so good. So there's now protocols in place that can help you diagnose the type of lesion. There's been an introduction of whitening and 3D whitening trays. So in the past, whitening was sort of up to the dentist if they wanted to do it with Icon. But now actually for, I would say 99% of cases, they all must do whitening before they have the Icon treatment because it helps reduce the size of the spot and it removes any brown or yellow discoloration from the tooth, allowing the treatment to be more successful. And then you've got the surface conditioning. So this is on the day of the treatment when the patient comes in for the Icon treatment. You need to have assessed prior to that appointment how deep the lesion is, so that if you need to use extra techniques to access the lesion, in your head, you've already pre-planned for it. So it's not I think I'll need to do this on the day. Before the patient comes in, you already know you're going to need to do X, Y, Z in order to get the best result. And then with the infiltration, there's variations on time and how deep the infiltration can penetrate. So we'll go through all of this step by step to help you understand on how to treat these areas. Now, when it comes to tooth discolorations, we have to make sure that we diagnose correctly on what's causing the discolorations. So in general, discolorations can be caused by extrinsic factors or intrinsic factors. Now, extrinsic factors are easily modifiable because it's something that the patient is doing. So it's a habit that they can change. So for example, if they're not brushing very well, you can get them to see a hygienist. If they're smoking, getting nicotine staining, you can ask them, to quit smoking or reduce the amount of cigarettes that they're having. It could be if they're having any oral antibiotics, if they're having any heavy colored food, so food which has a lot of turmeric. There's studies now that show that patients who eat a lot of fried food, their teeth tend to be more yellower because the oil molecules can leach into the tooth. And then, of course, certain drinks like coffee, red wine, or anything like that. So extrinsic is quite easy to deal with because you can diagnose it and then get the patient to change their habits. Now, with intrinsic, it could be due to a variety of different reasons. So it's really important when the patient first comes in that you try and figure out exactly what's caused it. If it's a single tooth and the whole tooth is discolored, so it's got a yellower color or maybe a gray color, chances are it's post-root canal treatment. So always take periapicals of these teeth, the radiographs to ensure that nothing else is going on with the pathology of the teeth. It could be if the tooth has undergone some trauma. It could have been if the patient had lots of antibiotics like tetracycline when they were younger, they'll have banded staining. Or it could be due to something that's happened at birth. So it could be either during pregnancy, at the time of labor, or within the first few years of life. And it's these three areas that normally cause these white spot lesions on teeth because that's when the enamel is developing onto the teeth. So if we look at the etiology of white spots specifically, we know now that we're living in a world where there's a lot more chemicals in the air. There's a lot more environment pollutants. There's a lot more plastics in the food that we're eating. Sometimes mothers may have infections while they're pregnant. They may have a lot of morning sickness. It could happen during labor. So maybe there's a premature birth. There may have been twins, oxygen starvation, or it could happen during the first year of life. So it could be that maybe the child had a lot of fever, so they're in and out of hospital. They could have lived in an area where the fluoride content of the water was very high. So there's lots of different reasons to why patients could get white spots. And sometimes it's very, very difficult to diagnose exactly what has caused it. But it's our job as a dental profession to try and educate our patient and the parent in what could have caused it. And sometimes there may not be a cause. So recently I had a patient who came in with her mum, and the mum said, the patient's been completely fine, absolutely no medical history concerns. And then I just, I said to her, chances are, more and more children are suffering from this. 1 in 8 children actually present with some sort of anterior discolorations. And its chances are it's down to the food that we're eating, the plastics that are in the air, the microplastics, they're in everything we're drinking. So even if you can't find an exact pinpoint position, try and investigate into what could be causing it. Now, when we think of spots, we have to think what is missing. Why is it that some children have these white and brown spots on their teeth and others don't? So I always give the example when you're doing a general checkup, an examination on a patient, and a lot of the time it will normally be between the premolars, and you can see a white area interproximally. And even before you take a radiograph, that there's going to be a big cavity in that area. So what's happened to that tooth? So the tooth has developed normally, and then they've lost the minerals, so they've lost the calcium and the phosphates due to incorrect toothbrushing and poor diet. And so you've lost the minerals, so you've ended up with a cavity, but you've got that white appearance. Now, in patients who appear with white spots, especially on the anterior teeth, they've never had the minerals and they've never had the enamel rods laid down correctly. So it's a developmental defect. When you look under a microscope at a healthy tooth, you'll see all the enamel rods are laid down in a nice uniform prism. When you look at a tooth that has a white spot, under a microscope, all the prisms are laid down haphazardly, so they're not all symmetrical or uniform, they're all over the place. So that's telling us that the minerals in the area haven't developed correctly, and that's what's caused the hypermineralization of these areas. So the first thing to start off with when a patient attends your practice is taking photos. So in general, I take a full set of intraoral and extraoral photos for all my new patients. But when you're dealing with patients with icon treatment, it's always good to get the anterior teeth. So the settings I tend to use on my Canon camera, shutter speed 1/25, aperture f22 or f25, and ISO 200. You may need to play around with your settings, but we get extraoral smile photos, and then we get lips retracted, and then we'll get a black contrast photo. If you start doing a lot of cases, I'd strongly recommend that you get a cross-polarized filter, which you can either place on your ring flash or on your twin flashes. So you can get these from Polaris. They're called Polar Eyes. And what a cross-polarization filter does, it essentially removes all the extra colors of the teeth, and it really just shows you what you're dealing with. So it can help diagnose the depth of spots. It can help show you the outline of the teeth. It can show you areas which may not be visible with your normal flash. So in this case here, the pictures on the left are with the cross-polarized camera, and the pictures on the right are with my normal camera. So when you look at the cross-polarized camera, you can really, essentially, you could get a pencil and you could draw out the outline of the white spot completely. So that will give you an idea, an indication of how deep the spot is. The more opaque the spot, the more difficult it's going to be to treat, because it means that the spot is running thicker throughout the enamel and the dentin. If the spot is not so opaque, or if it's more superficial, the more easier it will be to treat because it's in the enamel layer. So all these different things as part of your consultation book will help you decide how difficult or how easy this case will be to treat. Some questions to ask the parent or the patient when they come in. So the first one to ask is, what age did you notice the discolorations? So if the patient says, oh, my teeth were completely fine, and then I had a brace put on, and once the brace came off, the orthodontic brace came off, I noticed all these white marks around my teeth, then you think that this is a condition which has happened later on in life. So the white spots will be more superficial, so they'll be easier to treat. So that's essentially white spot carious lesions. And if you were going to start off with a case, so if you had your first icon case, that would be the first case to start off with, because it's happened later in life. It's going to be a lot more superficial, so it'll be a lot easier to treat. You will also want to ask your questions that we spoke about earlier. Were any antibiotics involved, any labor issues, any premature births? If it's a single tooth with one white spot and no other tooth is impacted in the mouth, then you think, could it have been trauma? So then you'll ask questions about trauma. Oh, did anything happen when the child was younger? Did they knock a baby tooth, which may have damaged the adult tooth? They might, so you have to think about what you're seeing and then ask the question specific to that. The other question you want to ask is, how many teeth are impacted? Because a lot of the time, the patients will appear when their central incisors and the lateral incisors have erupted. So your canines are not present. And if at that point the central and lateral incisors are impacting the patient's life and you start to do treatment, you have to warn the parent or the patient that, by the way, there's a possibility the other adult teeth may also be affected. So in the future, the same treatment may need to be done again. So we can either do the treatment now, or we can wait till the child is a bit older and do the treatment. This is a great little table. It shows you when initial mineralization occurs. So let's say the mother came in and she said, yep, for the first year of the life, the child was in and out of hospital. Then in your head, if you know when teeth start to mineralize, you'll know that, okay, the central incisors, the lateral incisors, and the canines could possibly be impacted, and the first molars. So if the patient comes in when the central incisors have come out, but not the lateral, and the mum tells you, well, they had an illness in the first year of life, you can then say to the mum, well, there's a possibility other teeth may also be impacted. So should we delay treatment and wait for the other teeth to come through, or should we just go ahead with treatment, but know in the future you may need to come back? So it's all about trying to educate your patients about what could be causing it and how treatment will be carried out. Another part of the protocol which has come out, which is very, very useful in helping diagnose how easy or difficult it's going to be to treat these areas, is transillumination. So what transillumination essentially means is you just hold a light from the palatal aspect and shine it through, and you will be basically looking from the buccal aspect to see how deep the lesions are going. Now, my recommendation is that you use a white light. Reason being is you can stare directly at it. If you don't have a white light, you can use your UV curing light, but remember, you don't want to stare at that for too long. So if you don't own a white light and you don't want to invest in a very expensive one, just use a basic, flash torch or something like that. Just you got Velo, which do quite a nice microlux light, or you can put it on with a diffuser lens. So there's lots of different options there. It doesn't have to be anything fancy, but the whole idea of transillumination is you can use that throughout the whole process. So you can use it on the day of the consultation to help assess the lesion. Then you can use it after the patient's completed the whitening to see if the spots have shrunk. And then you can use it on the actual day of icon treatment to see how well your infiltration is going into the tooth. So the benefit of the white light is because it doesn't set any resin, you can use it after you've put the infiltrant on the tooth to check, have I infiltrated the tooth enough, or do I need to leave the infiltration on for longer? There's a fantastic journal which sort of explains how to use it, and it basically shows that the lesions monitored under transmitted light require statistically significant longer infiltration time. So essentially, if you're using transillumination, you'll be able to accurately monitor how well the spot has infiltrated, and a lot of the time you'll realize that it's not infiltrated enough, so you'll do it for longer. Sometimes we rush and put the light cure onto the tooth too quickly, and it hasn't completely infiltrated. So it's a great way to help you assess lesions and with treatment. And it's a technique used to map and classify demarcated lesions on permanent anterior teeth using reflected and transilluminated light. So when you use this technique, if you see a diffuse border, then you know it will be a mixed or deep lesion, so it's away from the surface. If you see a demarcated border, that means it's more superficial. So if I show you on this next slide, so this patient attended for a consultation. So we took her photos and then I took a cross-polarized photo like this. What this allowed me to do is it allowed me to roughly mark up where the white spots are on the teeth. So you can see on the central incisors, the two white spots are very opaque. They're going into the dentine layer from the enamel. So that's telling me these two teeth are probably going to take slightly longer to treat than the lateral incisors. And because the white spots are so opaque and they're going into the dentine, I know that in order to remove these white spots completely, we're going to be removing a fair amount of enamel and dentine. So I will need to do some composite bonding to replace that lost tooth tissue surface. So on the day of the consultation, I can tell the parent, by the way, on the day we do the icon treatment, 2 composite fillings will also be needed to be placed on the buccal surface. Otherwise, you're going to be left with a defect on the tooth. And sort of this was the end result. So you can see before we did any treatment, and then afterwards, we can see that just there. And then you can see a result just there. So she was fairly happy. We've done a bit of composite on the central incisors, but on the lateral incisors with just an icon alone. Now, if I hadn't picked up on that prior to the day of treatment, I would have been sitting there maybe doing like 3, 4, 5, 6, 7, 8, 10 etch cycles, and it wouldn't have removed the white spot completely. But because I knew the white spots are very opaque, I used extra techniques like macroabrasion to help remove the surface layer to allow me to penetrate deeper, and then I can replace the lost tooth tissue with composite bonding. And what you're trying to do is you're trying to figure out where the white spot is within the tooth. So the image on the left of the screen, that's very superficial. So if a patient comes in with a white spot that's superficial like that, that's really easy to treat. You can normally do it within 3 rounds. You don't need any extra measures. Now, the image in the middle is probably one of the most hardest spots to treat. Reason being is you've got a spot which is within the enamel and dentine layer, but you've had normal prismatic enamel laid on top. So if you just use icon etch and you're trying to penetrate to where the aprismatic enamel is, you'll be there for ages because your normal icon etch is 15% hydrochloric acid. It removes about 50 microns per cycle. So you're going to need to do many cycles before you even get to the white spot. And then the third image on your right-hand side, that's a very deep lesion. So it's going into your enamel and your dentine, but it starts on the outer surface. So even though you're going to end up needing to do composite bonding because you're going to have to remove a significant amount of that white spot, it's actually going to be easier to treat than the image in the middle where you have healthy enamel on top because that's a lot harder to penetrate. Now, with treatment options, there's lots of different treatment options that can vary from whitening, icon treatment, composite bonding. The only treatment which we never want to do is placing indirect restorations because we know that once we start cutting teeth down and we're sticking indirect teeth on permanently, they'll always need treatment for life. So to date now, I've been using icon for about 5 to 6 years, and we've never had to redo any icon treatments because we're following the protocols and the step-by-step process. Now, with whitening or bleaching, what it does is, of course, enhance aesthetics, but it's the only product that you can really offer a patient that is non-invasive. So when the patient first comes in, I always say icon is minimally invasive. We're still removing microns of tooth tissue, but whitening is the only thing I can offer you which is non-invasive. So whitening and hygiene appointments are the only non-invasive treatment. Even something as fissure sealants, you're still removing a little bit of enamel tooth tissue. It's not much, but compared to whitening, there's nothing else that beats it. So I always say to patients, we start with whitening first. It's a disinfectant. It will help clean out the tooth. It will remove any yellow colors. It will remove any brown colors in the tooth. A lot of the time, as soon as the patient has started whitening, after a couple of days, they'll notice the yellow and the brown markings being removed from the tooth. And that already will start boosting their confidence. So it's a fantastic way to start the treatment. And also a study was done recently which shows that by doing whitening first, it will help actually reduce the size of the white spot. So because it increases the whiteness of the teeth, it reduces the color difference, and it also removes organic residue, which is essentially the protein, the yellow area from the tooth. And if you have a lot of yellow areas in the teeth, that can inhibit infiltration. So sometimes patients will say, or parents say, oh, I don't want them to have the whitening done. But then I say to them, but the result for your icon will not be as good because there's too much protein or yellow area into tooth, and icon only tackles white spots. It doesn't tackle brown or yellow spots. So we start with the whitening first to help remove any extra discoloration, and then we go on to the white spots. Now, you can buy the Vita Easy Shade. It's a fantastic device. You point it onto the tooth, and essentially it will tell you the shade of the tooth, and it also tells you how likely the tooth is going to go. It shows you a bleaching capacity. So if you've got a patient and the shade comes up with like an A3, you'll probably get a good bleaching score on it. If you've got a patient with a C or a D, 3 or 4, then you know it's going to take them a lot longer to bleach their teeth. So in those patients, you'll want to pre-warn them and say, by the way, your whitening case might take a little bit longer than someone who's an A shade, and you're preempting them that they may need to buy more extra whitening syringes from you. Now, Dr. Van Haywood has written many articles on whitening, and he has a set whitening protocol. So his protocol is that when you start whitening, you only give the patient the upper tray and you bleach the upper teeth for 3 weeks first. Reason being is that patients forget what their teeth look like, and sometimes they may come back in and they'll say, oh, my teeth haven't gone whiter. They completely forget what their teeth used to look like. So luckily, if you've taken photos and taken a shade before you start, you can always take some more photos and compare them. But the benefit of doing the upper teeth first is that there will then be a direct comparison to the lower teeth. So then the patient can at least see at home, oh, yeah, I can see the upper teeth going white. This is also a good protocol for children because a lot of them, they'll struggle wearing upper and lower whitening trays. They find it a little bit too bulky. So I always start the whitening on the arch, which needs to have the icon treatment done first. Then you review the patient, review the shades, and continue if needed. So it may be that the canines are still a bit yellower, so then you focus on the canines. If there's any brown or yellow areas left on the white spots, then you continue with the whitening until I would say you get 90% reduction of those of those yellow and brown areas. Once you're happy, you can then move on to the lower teeth. Now, in the UK, we're restricted on the concentration of whitening gel, which we can use. So we can only use up to 16% carbon peroxide or 6% hydrogen peroxide. Now, in general, for most of my patients, I will probably go to 10%. That's my go-to. In some patients, I will use 5%, and those patients are the ones who have very, very sensitive teeth or very young patients. And 16% I tend to use for top-ups. But you may have your preference. You may know what works well in your hands. Now, at the moment in the EU, whitening gel is considered cosmetic. However, DMG have just recently bought out their own whitening gel, Fluores, which has been medically approved in the EU. So it can now go down as a medical product. Unfortunately, in the UK, it can only be approved as a cosmetic product, so it will be used as just like the rest of the other whitening gels. At the moment in America, I'm not sure what the situation is, but hopefully if it can be approved medically, then you can use it on younger children without facing any issues. And another part of the treatment plan are 3D printed whitening trays. So currently in many offices, we will either take impressions or a digital scan and we'll send them off to the lab. The lab will then print a model and then they'll place thermoplastic material across and then they will make vacuum formed whitening trays. Now, the benefit of a digital printed tray is that you can get optimal fitting. The margin, the sealing of the margin is fantastic, so you don't get any leakage of the whitening gel. Now, a lot of the time people get sensitivity because the whitening gel goes from the buccal surface onto the gum line and onto the platal surface. The benefit of 3D printed trays, because you don't have a model, you're going straight from scan to print, is that you remove those areas and you can customize the trays as well. Now, I know you can get the special hubs, DMG Hub Labs, where you can try their 3D printing tray options. This will give you a chance to utilize the 3D printed trays before actually investing into a machine. And the biggest benefit is the sealing reservoir edge line. So it will seal just before the gingival margin. That means you're less likely to get leakage of the bleach. And you can see here a case on the left with a 3D printed tray. The blue dye is the bleach, so it stays just on the buccal surface. It's not going above the gum line. And on the right-hand side, it's a regular thermoform tray, and you can see that the bleach is going all over the place. So I think 3D printed trays, this coming into the, with digital dentistry, it's coming to the forum, but that's something to look out for in the future. So with ICON, what is it? How does it work? So ICON stands for the infiltration concept, and you have it for anterior teeth and posterior teeth. Now, in the EU, we call it ICON vestibular, but in America, it's called ICON smooth, and that's the one that you want to buy to do the treatment for anterior cases. If you're using ICON for proximal cases on posterior teeth, then buy the proximal kit, but we won't be talking about that one today. But when you're buying the kit, please don't get confused. Buy the right kit, ICON Smooth. Now, recently, there's been a new development in the ICON Smooth kit. It comes with the ICON Etch, the ICON Infiltrant, and now it comes with ICON Prime. So historically, the ICON Prime used to be ICON Dry, which was 99% ethanol. ICON Prime is still the 99% ethanol, but it now also has MDP. And MDP helps optimal penetration of the lesion. It enhances wettability and adhesion of the infiltration, which supports the best outcomes. So it helps surface condition and it helps with the infiltration spread more uniformly. So it's a key benefit of using the ICON product. A lot of time and money has been invested into the research of it. So it's a great new tip, which we're getting even better results than we were before. So inside the kit, you'll get the ICON infiltrant, and that's what comes in a black syringe. you'll get the icon etch, that's your 15% hydrochloric acid, and you'll get your icon prime. So that's your test. Now, it's really important that you use the kits as it's instructed. So the icon etch first, the icon prime, and then the icon infiltrant. You only move to the icon infiltrant when you are happy that you have successfully gained enough access to the lesion. So I tend to not open the infiltrant tube until I'm happy that I've gained enough access. The infiltrant is very unstable, so it can set with your overhead lights, hence why I only open it when I need to use it. And with the kit, you also get vestibular tips. These tips are really nice because it allows you to rub the gel or the infiltrant into the tooth. Now, the main difference between your regular phosphoric acid, which you use for your composite bonding, that removes sort of maybe 8 to 10 microns, whereas your hydrochloric acid can remove around 50 microns per cycle. So it gives quick and reliable results. You can remove a bit more tooth tissue, and you want to leave this on for 2 minutes per cycle, and then rinse it away. And essentially what you're trying to do with the icon etches, you're not trying to remove the whole white spot. All you're trying to do is remove enough of the outer surface so that when you put the infiltrant onto the tooth, it will penetrate even deeper onto the tooth. This is a little diagram to explain what goes on about white spots and why we see them as white spots and how the infiltration technique will work. So in a patient who doesn't have a white spot, the light bounces to the spot, to the tooth, and comes back in a straight line. Now, in a patient that has a white spot, when the light bounces towards the tooth, which has a white spot, it doesn't come back in a straight line. It comes back all over the place. Because as we discussed earlier, we know the enamel prisms and rods are not laid down correctly or uniformly. And essentially, the whole reason this is happening is due to a variation of the refractive index. Now, what icon infiltrant does, it fills in the area, and then it changes the refractive index similar to that of enamel. So when the light bounces to the tooth and then comes back to the eye, you can no longer see it. So the spot is completely hidden. It's camouflaged. Now, isolation, is it needed for icon resident infiltration treatment? Well, in general, I tend to use a rubber dam for most of my treatment. It allows excellent moisture control, soft tissue retraction. It's great for patient safety if you drop anything in the mouth, prevention of infection transfer, and to be honest, it's stress-free dentistry. My left hand just stays by my side for most of the treatment. My nurse is not stressing about suction or retraction or anything like that. But the most important reason to use a rubber dam when doing icon treatment is because you are using 15% hydrochloric acid and you are placing this on for 2 minutes per tooth. And sometimes you may need to do 3, 4, 5 cycles of this. Now, if you are not using a rubber dam and the icon etch goes onto the soft tissue, and you haven't realized and you haven't rinsed it away, you've just forgotten about it, or it's escaped down the side. And if it's left there, it can cause tissue necrosis. So if you're not using rubber dam, please be very, very careful. You don't want to risk causing any chemical burns into the patient's mouth. Now, which rubber dam system to use? So all latex rubber dams are okay with the icon treatment and the icon infiltration. I tend to use latex-free rubber dams for most of my treatment. So my favorite one is the blue one, the ISO dam, but there's many different companies available. The only one that I would say is definitely not to use is this one by Coltine. It will melt when you start putting the infiltrant on the teeth. So don't use that one just there, but there's lots of different options for whichever one you want to use. You can also use a mini dam as well, so that will isolate just 2 teeth. So if you want to, you can use a couple of them and you can isolate 6 adjacent teeth at a time. But remember, be careful when you're rinsing off the etch, make sure you suction it straight down and you don't let it go down the back of the throat. Now, sometimes some clinicians choose to use liquid rubber dam. The problem with using liquid rubber dam is sometimes if you do a lot of in-chair whitening with Zoom whitening in chair, and you've used this liquid dam, you'll find after a while the liquid dam will start to lift And so you then get a gap between the gum, the tooth, and the liquid dam. Now, with whitening, it's not the end of the world. You may whiten the gum and obviously it will recover, but it's the same problem. If you get any icon etch underneath the liquid dam and you haven't realized and you leave it there, maybe, it's just sitting there throughout the treatment, you haven't picked up on it right till the end, then you'll cause tissue necrosis. So please be very, very careful if you're going to use a liquid dam, that it doesn't get trapped underneath if it starts to lift. And so the treatment protocol, the patient, you've done your assessment, you've seen how deep the lesions are, the patient's gone off, they've done whitening for a couple of weeks. Then remember, you've got to have a 2-week break after finishing whitening and starting any bonding or resin treatment to allow the bond spread to go back to normal. The patient will come in, you'll do your isolation, you'll place your enamel, your icon etch for 2 minutes, you'll go to your icon prime, and you'll keep going between your etch and your prime until you're happy, and then you'll go into infiltration. And in some cases, you may need to restore with a composite as well if it's a deep lesion. So we're just going to run through this case here. It's a step-by-step process. For the purpose of today, please ignore the upper left lateral incisor or tooth number 22. That tooth ended up needing a root canal and a crown on, so completely different to the treatment we're talking about today. So a female of 23 years of age presents, and she's got these white spots on her teeth. She says, I've had them since the teeth came out, and I've always been told nothing can be done. And I was waiting until I had enough money to get some veneers put on. So I said, okay, great. So we've done our assessment, we've taken our photos, we've checked with the transilluminator, and we can see that the spots are quite deep, they're quite opaque, they're going into her dentine. So we start her off firstly with whitening. So she does 3 weeks of whitening at home, and you can see already on some of the teeth, the spots aren't so visible. So we get her to have a 2-week break after she finishes whitening, and then she comes back in. We pop on our rubber dam. So nowadays, I don't tend to use clamps as much. I tend to just use wedgets, because a lot of the time this treatment I do without giving any injections or local anesthetic. So actually, I say the most uncomfortable point of the appointment is actually putting the rubber dam on. So this is sometimes I try and do it without the rubber dam clamps, or just use wedgets. But she was an older patient. In younger patients, it's a bit more difficult to put clamps onto their teeth. So that's where the wedgets can come in quite handy. So we started off by placing the icon etch on the teeth, and you can see the vestibular tip. So that's allowing us to rub the icon etch into the teeth. You can see some bubbles. That tells you the etch is working with the tooth, so that's a good sign. And your nurse can set a 2-minute timer, and you can be rubbing in the icon etch onto the teeth, and that just leave it, or you can leave it, and after 2 minutes, you'll rinse all the icon etch away. Then you'll put your icon prime on. So it's really, really important that during the stage that you really concentrate and look at the tooth. Because when the tooth is dry and it has nothing on, you will see the white spot clearly. But when you put the icon prime on, if the white spot disappears, that tells you you can move on to the next stage. But if the white spot is still there, then you must go back to the icon etch stage. Now, it may be partially some of the white spot has disappeared and part of it hasn't. Then you know that, okay, I've only removed it in this area. I need to go back and do focused icon etch in another area. So it's really important you focus at this stage and try not to skip out. So you don't want to just do etch cycle after etch cycle after etch cycle. After every etch cycle, make sure you check it, because you don't know when the lesion will be ready to infiltrate. If you're looking with your eye and without the prime, you're always going to see the white spot. But as soon as you put the prime on the tooth, it will rehydrate the tooth. And if the spot has gone, you know you can move to the next stage. With the etching cycles, the first etching cycle, you're always breaking through that hard exterior barrier. Remember, the patient has been using fluoridated toothpaste. That outer area is always going to be a little bit more hard to break through. But once you break through that, every time you do an etch cycle, you're going to be removing a little bit more of that white spot. So that's why it's really important to check it. Now, when you're happy, so in this case, I think we did about 4 cycles, and I used a little bit of air abrasion just to help me here. Once you're happy, this is when you'll put your infiltration in. So normally at this point, I switch the overhead light off. I switch my office lights off. If there's a window, I'll close the blind. because I don't want anything to set this icon infiltrate early. And then you'll rub the infiltration onto the tooth and you'll just leave it there. And the minimum time is 3 minutes. Now you can leave it on for longer if you want to. So if after 3 minutes you have a look and you think, oh, I can still see some of the white spots, add a little bit more of the infiltrant on and then just cover up the teeth again. So I tend to use you can either use some foil or you can use like a plastic cover, anything which is not going to allow light to penetrate through. And you can leave the infiltrant on for as long as you need to allow the areas to completely penetrate. Now, in this case here, I placed a little bit too much on, so you can see there's a bit at the back of my rubber dam. So make sure you suction up any excess before you light cure. Reason being is if you start to light cure this before, before you remove any excess, it will become very, very difficult to remove at the end. So this is just a small video showing you how the infiltrant works. So you can see you're just touching the infiltrant to the outside, but can you see how deep the infiltrant is penetrating? And this is exactly what's happening in the mouth or on the teeth, basically. So you just, every now and then, you're going to go back, you're going to massage the infiltrant from the outside, and it's going to penetrate deeper into the tooth. And can you see how this is a bit of quartz, but how it looks completely different to a minute ago before any infiltrant was put on? So the whole refractive index, the color of the tooth has completely changed. And this is exactly what goes on inside the mouth and on the tooth. And so once you've infiltrated the area, you've changed the refractive index to similar of enamel. And so the spot looks completely disappeared. So very important, make sure you light your each tooth for 40 seconds. It's very, very important you do not rush the light cure stage. And once you've done it once, you need to go back, repeat the infiltration process for 1 minute to ensure if there's any polymerization or any shrinkage, you've covered those areas, and then light cure again for 40 seconds. A lot of the time, if you rush the light cure, you haven't given enough time for the photo initiators to go from the yellow color to clear. So sometimes if you do an icon case and you say, well, the teeth have come back looking yellow, it's because you didn't light cure for the full 40 seconds. So you must do 40 seconds per tooth. This is a great example because it shows you, if you look at palette number 2, that's 10 seconds, 3 is 20, and then 4 is 40 seconds. So 40 seconds per tooth after every infiltration cycle. Now, if we just go back to this case and show you, if you look at tooth 21, you can see there's quite a big groove on the tooth because the spot was quite deep. Now, luckily, I picked up on this on the day of consultation. So I had told my patient already, as part of your treatment, you're going to need some composite bonding because if I do the icon treatment alone, the white spot will disappear, but you're going to be left with a little divot or a groove on the tooth. So on the same day of treatment, you can do the composite bonding. And you do that just using your regular etch, your regular bond, and then you stick single shade of enamel or a body shade on top of the tooth. Remember to take your shade before you put the rubber dam on because dehydration will cause the shade to change temporarily. And then when you polish, make sure you polish really, really well. The infiltrant is quite runny, so it can get in between the teeth and it can sit where the rubber dam is. So when you take the rubber dam off, make sure you polish really well with discs and brownies and ASAP polishers, anything that you use for your regular polishing. And then before you hand your patient the mirror, remember to tell them, because your teeth have been under a rubber dam for like an hour, hour and a half, the composite or the icon treatment may look slightly different. but want come again in a couple of days and everything will look okay. So this was the result at the end. And it looks good, but I told her, don't worry about those little round sort of yellow areas. That's where we've done the composite. And then we fixed the upper left two tooth for her, and she came back, and you can see everything's sort of rehydrated, and it's a great result. And it was all done without any anesthetic, no drilling. So a great result for a patient who was getting ready to have essentially maybe like 10 porcelain veneers on her teeth. And she may wish to do that in the future, but at least this treatment now has made the tooth stronger. And this may be enough for her. We've done a great treatment for her without much loss of the tooth tissue. And I'm very, very fortunate. I've done, I get to see many, many patients of all different ages who come across for treatment. And you can see, this treatment can be used for anything really. White spots, brown spots, mixture of spots. And the youngest patient I treated was an 8-year-old on the left of the screen. He had stopped going to school because he was very conscious of his teeth. So mum knows that there's a high possibility when his next set of teeth come through, his laterals and canines, he will need them done. But this was enough for her at the time. We did this treatment and he's back to school now, which is great. And then the patient on the right he had come in to see the orthodontist, and the orthodontist had asked me to build up the central incisors. But at the same time, she said maybe discuss icon with the patient. And so we did some icon treatment and we built up the central incisors, and he was super happy. And actually after that, he said, oh, I'm not sure if I need a brace on. I'm really happy with the results of my teeth. But I said to him, no, go back and have your brace put on because you've got a bite issue and everything to get sorted. And sometimes patients ask, can I have it done before having a brace on or after? Well, I always say the enamel is weaker. If you stick a brace onto a weaker tooth, there's more likely they may get decay around there or white spot lesions, or the brackets may debond. So actually, if you get the treatment done before, you're making the tooth stronger and healthier, and that way it will last a lot longer just there. Fantastic. And this is just a little video to finish off with, just showing you the treatment. So here you've got your icon etch, and everything in the icon kit is a twist. Normally we're used to pushing with our thumbs, but the whole kit is a twist kit. And then you've got your icon prime. The same again, it's a twist kit here. And this is your icon infiltrant. You can see it's quite a strong yellow color, but remember, once you light cure it, it will go translucent. So there's a mini dam on here in place so you can see what it looks like. And we're just placing the icon etch where it needs to be placed. With a 2-minute cycle per icon etch cycle. Maintain surface contact, so you can agitate, you can use micro brushes, you can use the vestibular tip, whichever you prefer. And then you'll use your icon prime, used to be called icon dry. You'll be dropping a couple of drops, only need 2 or 3 drops. Visually have a look at the tooth, see if the white spot has disappeared. If it hasn't, go back to your icon etch. If it has, then you go onto the icon infiltrant, and this time you're going to be placing it on for 3 minutes. So before you you'll remove any excess, you can use your big suction and floss in between, and then make sure you your 40 seconds per tooth. And then you'll repeat the infiltration stage just for 1 minute per tooth. And then same again, you'll light cure for 40 seconds at the end. And once you're done, make sure you polish any excess away, and you can get a great result. And thank you so much for everyone who's joined me today. I hope you've learned something, and if you have any questions, feel free to put them into the chat. Thank you so much. Okay, so I'm just going to read out a couple of questions. So question is, what brand of composite do you use? To be honest, I'm not really set on a particular brand. I've used DMG, EchoSight composite. I use Genial, Accord. So it just really just depends on the case. I'll always do like a color check before, and then whichever color looks the best, I'll go for that one. So there's a question, why do people get white spots after braces are removed? So that's due to poor oral hygiene when the white spots are on, when the braces are on the teeth. So if you imagine they've got a metal structure stuck into the tooth, they're not cleaning well, they're getting plaque buildup there, and they're getting early demineralization. So it's the early start of decay. So when the brace comes off, it becomes a lot more obvious, and those are the easiest treatments to treat. Someone's asked, how much do I charge for this treatment? So I charge a very similar price to what I charge my composites fillings for, and then I'll just add the fee of the icon kit on top. So whatever you charge in your office, charge that, and then you could just add the charge of the key. Unfortunately, I've been asked a question, is it billed to insurance? In the UK, we don't have an insurance system, so I'm not sure what the answer would be. I guess you could charge the same as a composite and then maybe charge a fee for the product or something like that. So there's a question, do patients get much sensitivity after the use? So far to date, not had any patients who have had any sensitivity with the treatment. Even during treatment, not many of them, I asked them, are you okay? And they always say, yeah. The treatment's a long treatment, so the patient's in the chair for about an hour, maybe an hour and a half sometimes. So you've got to make sure your patient is old enough to be compliant, but no sensitivity. So another question, does this help with graying of the tooth from trauma? So no, that's something separate. So with icon treatment for trauma, is the trauma will appear as a white spot. Now, if a tooth has gone grey, chances are that tooth needs root canal treatment and internal whitening. So that's a completely different treatment. So make sure if it's trauma causing a white spot, or is it trauma that's caused the tooth to become necrosed and they need root canal treatment. So a question, how do you use a rubber dam without numbing? Clamps always seem to hurt. So what I'd say is make sure you punch the correct size holes. So your holes are the correct size for the teeth. I always use the blue latex-free rubber dam. That's my favorite. And I say, do to the patient, the most uncomfortable bit will be when we're flossing the rubber dam, but I hold the rubber dam down with wedgets now. So you might have seen them. They're kind of like elastic bands. You can get them in different sizes, like yellow, blue, and green. And I tend to just floss those through, and that just holds the rubber dam sheet down. And if you do want to use clamps, you can always put, let's say you're doing the upper 3 to 3. So punch your holes upper 3 to 3, put the rubber dam on, and then with your clamps, put it on the 4, but put your rubber dam, your clamp will be sitting on the rubber dam, which will be on the 2. So rather than putting the clamp on the tooth first and then pulling the rubber dam over it, just leave the rubber dam without a hole and then just put your clamp on top, and that will just help protect the area. Thank you so much for all your questions, and I hope you've learned something from today. And if you still have any questions, feel free to reach out to me on my Instagram, and I really appreciate all your help. Thank you so much.